Hello. So my name is Stephen. I am Deputy Lab Manager at Care Fertility in Northampton, and we're going to be with Dr. Rima from Care Birmingham. She's the Medical Director and Consultant Gynaecologist there. We're going to talk you through a quick sort of summary of the whole IVF process, how you get started, what happens moving through the process, and kind of what happens when you get through to the lab processes. Obviously, that's my speciality, so I will talk quite a lot about that. And then we're going to roll through into kind of how care can help you and into IVF, kind of Q&A at the end of that. So obviously I'm going to introduce Dr. Rima, who should join me on stage shortly. Somewhere.
Hi. Hi, can you see me and hear me? Hi, Steve, hi.
Yes, yeah, I can see and
hear
you.
Good evening.
So yeah, I'll just introduce you. So we're going to be doing the Q&A at the end. Obviously, pop your questions in the chat box. I think if you put it in the chat box, you can see the first name in the questions tab. That just comes directly to our team on this side. And obviously, if you feel like anything pops up during that process, or as we're talking, pop it in the box and we'll answer it at the end. And obviously, if anything comes up at the end, feel free to ask away. So who are we? We're Care Fertility. Oh, it's come back on me. I now need to play a video, so bear with me. So this is our intro video.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic. And even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
So there we go. So yeah, basically across the UK, we see sort of 1 in 6 families struggling to have a baby themselves or struggling with fertility problems. We are a large private provider of fertility treatment in the UK. Obviously, we've got clinics now, not just in the UK, kind of across the world. We've got 1 in the USA and 3 in Spain. We've treated a large variety of couples as per the video, so heterosexual, same-sex couples, single patients. And we offer a huge variety of IVF treatments in the UK and obviously abroad now. We obviously will refer to a general IVF procedure, whether it's kind of donor sperm, donor eggs. Largely the process is the same. Any specific questions, obviously, we can kind of answer at the end, but the whole kind of IVF process kind of works in a similar way. And obviously what we see patient to patient kind of depends really. The first steps are obviously kind of contacting us. We have a general inquiries team who kind of deal with all incoming requests, and they're kind of really helpful in giving advice, guiding you in the right direction. They're kind of knowledgeable on how the process works, what sort of treatments you kind of might need, and they'll signpost you in the direction that you need to go. Obviously, they're available during the event and until 8 p.m. tonight, so you've still got time, obviously, once you've finished watching this. Obviously, our new patient inquiry team leader, Lauren, she is part of our events team and will be answering questions as well. So any questions about kind of becoming a patient, that kind of thing, direct them her way, and she'll be able to help you sort of signpost you in the right direction. So starting the treatment, obviously you would be contacting us, and then we move forward and start looking at diagnosis. So obviously the right diagnosis is really, really important. If you don't kind of get the right diagnosis, it's difficult to then treat the problem or look at how we can kind of help with that problem. Obviously we take quite a lot of time to get to know you, any previous history, any IVF treatment you've had in the past, or treatment even through the hospitals, just for sort of fertility problems. If things are recent, like blood tests, semen analysis, that kind of thing, that can be something that we can use. Obviously it has to be recent because that's kind of the most up-to-date relevant information we have about you. And obviously we have a patient portal that you can kind of, once you become a patient, you get registered for, you can upload all your documentation, all your clinical history, everything into that. And obviously before the consultation, this is all reviewed. Obviously they're looking at kind of what it is in order to gain kind of the most out of an initial consultation with you. The consultation itself, obviously we first start by listening to your sort of fertility plans, what you expect from the treatment. Do you expect 1 baby? Do you want 2 babies? Is that what your version of a complete family is? Obviously that's a really important part of understanding the best courses of treatment and how that might work out for you. We look at all the test results during that consultation. They'll explain whether they feel necessarily sort of tests might be useful for you. So do you need a more up-to-date semen analysis? Can we look at some other blood or hormone from you? Would that be useful in kind of getting any further with that. We give you kind of the different treatment options, so we'll discuss kind of what we recommend for you as well as different options you might have, and obviously we'll talk through the chances of success that we expect based on sort of the treatment that we're offering, the age category, any hormone levels, all of that sort of thing. So having that information available to begin with is really, really helpful for your consultation in order to get the most out of it. Obviously, we signpost you to the support we offer. We have kind of an extensive network of contacts within the company. There's counselling available throughout the process. So lots and lots of sort of signposting to where you need to go to certain things. We'll give you cost estimates for the treatments that we're offering, and any add-ons or things that we think you should consider as part of treatment. Obviously, it kind of starts off with knowing how much it's going to cost you, or if you're funded, what you could pay on top of that in certain NHS sort of areas. And obviously it gives you plenty of time to ask questions about kind of what do you not understand. It's a really complicated process, so we really understand that not everyone's going to go into a consultation and pick up all the information instantly, because I've been working there a long time, and every now and again stuff still trips me up. So and it's my job, so we're not expecting patients to kind of understand everything immediately. And you will get kind of a written summary of everything that's discussed during the consultation. So moving on to the kind of IVF process, how does it work? How do we treat patients? What do we look for? So the first real stages, they're kind of prior to sort of us generating any embryos, is the ovarian stimulation and monitoring, and then we'll move on to sort of egg collection, sperm collection on the main first day of treatment, which is more my area. So ovarian stimulation, obviously this is something that we use to kind of stimulate your ovaries in order for you to produce more eggs than you normally would during a cycle. So most women produce 1 to 0 eggs during a menstrual cycle if you sort of having cycles. What we do in IVF is kind of stimulate the ovaries with some hormones, and kind of regularly sort of increase the hormone levels just so you're producing more eggs, and obviously we're recruiting more eggs during that sort of cycle. Obviously it depends kind of, and it's completely personalized to you as to how much medication we give you, for how long, the cycle type we give. Obviously that's something that you gain from the consultation and the blood tests, etc., that we do, kind of workup scans and everything like that. The protocol and the medication giving, everything is explained by our nursing team. We have kind of a comprehensive set of videos that will talk you through, so no matter what time you're taking your medication, you can sit down, you can load up a video and they'll talk you through the whole process, and guide you with how to load your syringe, whether you're doing it right, where to inject yourself, kind of the best ways of doing things like that. And obviously everything is kind of monitored by the nursing team as well. And then we move to monitoring. So this is during your cycle where we are stimulating the ovaries, and we're kind of measuring how they're progressing, when's the best chance that we're going to collect the eggs most appropriately, how many are we expecting to get, and obviously this brings into it kind of regular scans in a clinic basis, and they're monitored by the team. So if we bring you in one day and we think, oh, not quite there, we'll push you for a scan in the next couple of days, or bring you in for a collection in the next couple of days, and kind of it's all personalized to you and how you progress through the cycle. We also change the medications and things like that as well, depending on how you respond to them, because different people respond differently to different medications. It normally lasts for sort of 3 to 7 days in most cases, but some patients are different and fall outside of that. We then give you a trigger injection, which is kind of a replacement, an artificial replacement for your normal kind of bodily hormones that produce that sort of surge that causes you to ovulate. So we're kind of replicating that, so we can give you a set time. This allows us to then sort of predict when you're going to ovulate, and then therefore sort of collect the eggs just before you ovulate. Obviously then what we do is plan the egg collection in sort of 36-ish, depending on your kind of history hours later. The egg collection itself is something that we do under sedation. It's kind of a day surgery type procedure. You'll be what's called conscious sedation, so you're sort of asleep, or some patients are awake, but it's kind of out of pain and you're not really aware of what's going on, and most patients don't really remember it. We use an ultrasound probe. It's pretty sort of straightforward. You use an ultrasound probe. We use a needle that goes directly through the wall into the ovaries. We can then obviously see where the follicles are, so the little black and white pictures, they show kind of follicles in the ovaries, and then we go in with the needle and we aspirate the fluid out of the follicle. This brings with it the egg. Hopefully not all follicles contain eggs, and we're not always able to retrieve them, but for the most part we bring one egg sort of from each follicle. As an embryologist, this is where kind of we have our first contact with the patient, and we're in the lab while the so Rima will be in theatre. She'll be doing the kind of the needle and the ultrasound probe. As a lab member, we'll be kind of looking through the dishes. We'll be spotting the eggs. Really, it's kind of like a game of hunt the eggs, and you're obviously then moving them into a specialised media and keeping them kind of at the correct temperature. So you're almost always keeping everything at 37 degrees. It's about a 30 minute procedure, depending on how many eggs you've got and everything, any kind of comorbidities, that kind of thing. And obviously then you'll rest on one of our wards until you're ready to go home. We've seen some recovery, you're feeling much better, and obviously kind of ready to go home. And you tend to recover fairly well. Within 24 hours you should start to feel better from the procedure. This coincides with the sperm collection, so obviously we need eggs and sperm to create an embryo. So normally this is done with a sample from the man, either produced at home, depending on how far away you are from clinic, or you can produce in clinic. We have specialised rooms and kind of everything you need to do that. We obviously are maximising the kind of number of sperm that are swimming and the kind of most sort of healthy. So we're then kind of preparing this. We do this in a couple of different ways. We use a kind of specialized media. We spin it around in a tube and it pulls the sperm that are moving or of the correct density to the bottom. We then prepare these. So we're sort of separating the sperm cells themselves from the seminal fluid. I think there's a video on here of it, so I'll show you that as well, and then you can kind of see what we're looking at when we see sperm. Perfect. So yeah, these are sperm cells swimming around, and what we're looking for is kind of a good count. Doesn't matter really, as long as there are motile sperm in the sample, and sometimes even if they're not moving, we can still use them for treatment. It just depends on kind of what we see. This is something that we pick up in the pre-workup anyway. As part of the pre-workup, we do a diagnostic semen analysis, so we can kind of see how many there are, what they're swimming like, and obviously what they look like. They're the kind of three main parameters. So how many are there, what kind of motility have we got, so how many are swimming, and then what those actually look like when you look at them down a microscope, because some of them kind of, you see all sorts of things: two-headed sperm, three-headed sperm, two-tailed sperm. I think I've probably seen all of them in my career. If there is a problem with sperm and it doesn't come out in the ejaculate, so certain sort of problems can cause different procedures, we can recover it surgically as well, and in a similar procedure to the egg collection, but obviously it's going straight into the testes and we're recovering the sperm during that process. That's kind of something that's separate to treatment, so we'll kind of normally get sperm prior to that, or if on the day, stage anxiety, something like that, then we can do a recovery that way. It's not always the best thing when you're not really planned for it and not expecting it, but it's not kind of the end of the world for, oh, we can't produce a sample. Obviously, if we do a diagnostic semen analysis, can't see any sperm in the sample, we normally do a surgical retrieval prior to this, so we know we've got sperm. If that's not the case, then we can discuss other options, hormone treatments, whether we can refer you back to a urologist or something like that, or obviously the other option is donor sperm. But that's something that we cover in a lot of detail normally prior to consultation. But as I mentioned, on the day we can also do that procedure if there's a problem. The second sort of phase, if you like, of treatment is when we kind of get the eggs and the sperm in the lab. So this is my job really. What we do is we fertilize the eggs with the sperm. There's two ways of doing this. So we can do what's called standard IVF, where we mix the sperm and the eggs in a dish. We leave them overnight, and it kind of replicates what you see in nature. So the sperm swimming through the uterus into the fallopian tubes and meeting the egg. Obviously, it's a much smaller concept, so they're only kind of swimming a couple of centimeters, but you're seeing the sperm meet the egg, and obviously the first one's there, and obviously that's normally something that we kind of use when we've got normal sperm counts, or your history is not too complicated, or there's a kind of a known reason, and it obviously kind of is the most natural you're going to get when you're doing it in the lab. It's really dependent on kind of sperm count and quality of the sperm as to whether we can do that. If that's kind of suboptimal, so if we're not seeing the numbers, then not seeing the motility, or they just don't look right, or sometimes if you've got an unexplained history, sometimes it's something smaller than we can actually see in a semen analysis. So we kind of recommend what's called ICSI. So in the video on now, you can see kind of the ICSI process. That's where we're picking up a sperm. So as an embryologist, we're selecting a sperm, and then we're directly injecting it straight into the egg. This bypasses all of the sort of natural processes that we would need for the egg and the sperm to meet, and our fertilization rates and everything else are absolutely kind of similar to with that. It doesn't really matter what the sperm look like, kind of because you're overcoming the need for it to be a good count or a good motility or a good kind of morphology. So you're overcoming all of that process by doing this ICSI procedure. Obviously, it can be kind of decided prior to the day. You'll know which one we're planning on doing, but obviously we will check the eggs, we will check the sperm during that process. I mean, if we feel that's not the right way of doing it, or not the right way to gain fertilization, we will come out and we'll kind of talk to you, and we'll go through everything and confirm the treatment as planned, or whether we recommend a different treatment on the day, because it's one of those things. Some men have completely normal samples, but on the day of treatment it just doesn't kind of happen for whatever reason, or sometimes the egg quality is different to what we expect it to be. Obviously, when we look at the next stage, so fertilization, we're looking in the next day, so we leave them sort of 16 to 18 hours, and we come back into the lab in the morning and we assess each of the eggs that we've collected the day prior to see whether they're fertilized or not. What we're looking for is two sort of rings, and they kind of represent the sperm DNA and the egg DNA, and you'll see in that in the lab between sort of 16 and 18 hours, and that's what we're looking for when we look for fertilization. Sometimes you get kind of one lot of DNA, sometimes you get 3 lots of DNA, 4 lots of DNA, just obviously for abnormal eggs, like abnormal sperm fertilization, or just the interaction process can kind of pick up abnormalities, because we've collected a lot more eggs than you would normally see, and we're doing that in the lab, and then we kind of put them back in the incubator, or sometimes we don't even take them out of the incubator. The next stage for us is to sort of let them do their thing for 5 days, and this is what's called embryo development, and it's kind of one of the jobs that is really the most important bit in the lab, and you're kind of assessing how the embryos develop over time, what they look like when they get to the correct stages, and it's sort of a whole new science really, is to sort of work out which embryo of the eggs that we've generated and the embryos that we've generated, which one of those embryos is the one that's most likely to go on to form a pregnancy, and being able to select that first time round. Obviously we monitor it, and we've got specially designed sort of incubators, culture media, so they kind of almost try and replicate the human body and what kind of would happen in the natural process when you're developing embryos. And we don't take them out of the incubator in order to sort of maintain that environment. They're all at a special gas concentration and everything like that. Obviously, we will call you at the fertilization step, and then depending on kind of what we've seen, and we may make recommendations to make further calls on sort of day 2, day 3, or normally we would just call you on day 5 of development when the embryos have done their thing. So this is an embryo developing. What you can see is kind of it go from sort of 3 cells, it all sort of divides up and then it merges together, and then you'll form what's called a cavity. It's almost like a deflated football, and it almost inflates. That's a really important step in embryo development, and it is something that we expect our embryos to do. So this is where it's what's called a blastocyst. You are allowing the embryos to get to this stage because most embryos up until day 3 look very, very similar. When they get to this stage, there's a lot more cells, there's a lot more steps in development, and being able to view those steps and see how the grading of those develops over time is one really important part of identifying which embryo is the one that's most likely to form a pregnancy. Obviously, we kind of have lots and lots of different ways of doing this, things that we look at as a lab team, and obviously as Care Fertility, we've got some really specialist kit really. It's all sort of developed in-house, and it's things that sort of most people don't really have access to just because of the size of the group that we are. Obviously, this video is what's called a care maps video. It's from a time-lapse incubator. So we look at kind of how it develops over time, how the grading happens. And another thing we can do is PGTA. So that's where we take some of the cells away from the embryo in what's called a biopsy procedure, which is what you can see here. We take from the bit of the embryo that forms the placenta. We then freeze the remaining embryo and send that embryo off, send the cells off for testing. This gives us a really good representation of whether the embryo is genetically normal, has kind of the right amount of chromosomes in it, or whether it's abnormal. Abnormal embryos that don't really form pregnancies, so we're kind of assessing which one of them are most likely to form pregnancies. This is a procedure that is not really applicable to everyone, but it's something that can be useful for a lot of our patients, and it helps to kind of speed up the time to selecting which embryo is the best embryo. Other things we can do, we've got diagnostic tests as well prior to this, so we can do what's called Care Unity, which looks for sort of, I think, miscarriage risk, but Rima will correct me if I'm wrong, and SOS testing, which is kind of looking at the oxidative stress on the sperm, and obviously the genetic testing that we do with PGTA. We also have clinics that offer specific gene testing for kind of hereditary diseases, and obviously we also look at fertility preservation, so we can freeze sperm, we can freeze eggs, or if you're in a couple and you just kind of not quite ready, we can freeze embryos as well. And obviously it helps kind of producing those embryos as early as you can, because they're kind of, you see a decline in egg number, in egg quality as you kind of get older, and sometimes sperm quality as well. So success rates across the group, we do really see kind of good success rates across the group, and obviously each kind of individual clinic has its own success rates, which are all kind of mapped out. And I think if you ask on the questions tab, they'll be able to point you in the direction for the success rates for each clinic. The final stage, once we've selected out the embryo, is the embryo transfer. So this is where you are selecting which embryo is the best, and then you undergo a procedure to be able to put the embryo back. It's guided by ultrasound, so we use ultrasound on your tummy. It's not internal this time. You'll need a full bladder for the procedure, and we kind of go in through the uterus with a really small sort of, it looks like about a foot long straw. We as embryologists load the embryo into the straw. We then pass it to a clinician who then kind of insert it through the uterus and put it back where it belongs, really, in the lining of the womb. It is something that takes about 15 minutes. There's no sedation necessarily normally. Obviously, if you do have problems, sometimes that can be an option for you. But for most patients, it's just a kind of 15-minute in-out procedure. You can choose to rest afterwards. I know some patients kind of worry about going to the toilet or standing up, that kind of thing, but it's not going to fall out. Yeah, we're kind of putting it back in that process. And obviously, kind of you can go about your normal activities normally afterwards. We then enter what's called a 2-week wait, and that's probably the worst part of the process for a lot of people. It's where you know you've got an embryo inside of you, you don't know whether it's forming a pregnancy yet. It's too early to pick anything up on a pregnancy test, and obviously we support you with some medication, so you'll be taking what's called progesterone or kind of a support drug that helps the lining sort of build during that process. And you'll take a pregnancy test sort of 14 to 16 days after the transfer, and then obviously we'll kind of know whether you're sort of positive or negative pregnancy then. And obviously if you're positive, or we will confirm that result in the clinic with a scan. If you're negative result, we have a lot of support available. As I mentioned earlier, we've got counselling, we've got consultations that we'll book with you. Obviously, that's something that you can do when you feel ready. It doesn't necessarily need to be I've done a negative test today, I'll book one straight away. It's kind of as and when you feel comfortable to do that. If you've got a positive result, obviously we'll scan you, we'll check the result normally around the 6-week mark, and obviously if you're pregnant, you'll be then discharged to your GP for kind of pregnancy care as normal. We also have a kind of a load of different options available as well. You've got your donation, and we've got a specialist donation team that deal with kind of all types of donations. So we know for a lot of people it's not kind of the same, and we are aware of all this process, and we have everything sort of in place to support that. There are many kind of reasons why you might need eggs, you might need sperm, you might need embryos, and we're kind of all set up for that. We have about 25 years experience in the donation sector, so a large amount of experience. We've helped more people start a family with donated embryos, gametes than any other clinic. We obviously will support you through the process from initial questions all the way through to kind of helping you select your donor, and we have specialist counselling available to support you with that. As kind of I've mentioned, we've got free counselling appointments, we've got a whole social media team. I'm sure they kind of get all sorts of questions through Instagram, Facebook, everything else, and we've got a 24-hour forum that you can go on. There's a lot of information on there from current patients, past patients, people who are prospective patients, and you kind of looking at that as a base of support. And I know people personally have kind of made friends on there through having treatment at the similar time, and obviously they've got a really good understanding of what you're going through. And obviously we've got the care support team available in clinics, and as an embryologist I love to talk about my job, so we like it when patients call in and ask us questions. It's nice to be able to sort of talk about what you do to someone, because a lot of the time we are just in our labs, and obviously it's available kind of every moment, and there's something available whatever time of day it is. We are obviously not just there kind of for the kind of treatment element either, where we try and help financially as well. We've got a customized package that's kind of in-house, completely sort of bespoke to what we do, and it doesn't mean you have to talk to different teams in different companies to sort out finance packages. It's all something that's done in-house, and a lot of the team are kind of aware of that. Obviously it's something that's completely tailored and kind of offers a bit more financial peace of mind, because we offer kind of multi-cycles, so you can pay for 2 and it gives you a bit of a discount over that time. And obviously it was something that we created from feedback about having to contact other clinics and organize it, and the talking between clinics. It's something that's done in-house. Before they come through to me in the lab, and I'm sure mostly Rima as well, actually, it's something that patients have decided on how much money they've got for the process, how much money they want to spend, what kind of the process is and how that costs, because that's something that's really important for a lot of people. So we're trying to help with that and kind of keep it personal and private. It covers kind of cycle monitoring, egg collection, embryology, embryo transfer, freezing and storage, unlimited embryo transfers, blastocyst culture, and also the care map system as well. So all of the AI process that we use to choose embryos. And I think that's probably the end of the presentation. Obviously, if you do call the new patient inquiry team, there is a discount on a consultation on offer if you quote the event, and that you've you've stuck with me and listened to me for kind of half an hour or so, and you didn't get bored, then obviously there's something in it for you as well. So now we're going to move on to the Q&A. So I think Rima's going to join me, and we're going to talk about kind of actually there's a video first, but I will kind of does the video come now or after? I don't know. I'm sure someone will tell me. But yeah, we'll do a Q&A. There's me, embryology, and there's obviously Rima. Okay, being told not to worry about the video, so there's no video. So not yet. Anyway, it's at the end. I will close that and we'll get Rima on stage.
Hi everyone. Thanks, Steve. That was interesting. I always love watching that video of the embryos developing. It's so beautiful. So just to introduce myself again, my name is Rima Rajkhowa. I'm a consultant gynecologist and a subspecialist in reproductive medicine. I'm also the medical director at Care Birmingham, and I'm delighted to be here today to answer queries that you may have about the treatment, or which you may already be going through or may be considering starting. So Steve, how do you want to do this?
Ask you the questions, Rima?
Yeah, you could do.
So the first one we've got is everyone on the same stimulation protocol during IVF?
Right. So no, the straightforward answer is no. Everybody is not on the same protocol. So as Steve had spoken earlier, the protocol means the part of the stimulation program that we have to devise for you so that you respond to the hormone injections with the right number of eggs. We don't want too many, nor do we want too few. So based on your initial assessment, which will be an ovarian reserve assessment, looking at your age, looking at how you may have responded to previous treatment, we then propose a treatment protocol for you. So there are different protocols for different patients. There may be a short or antagonist protocol. There may be a long or agonist protocol. In some patients, for example, those with severe pelvic endometriosis, we may decide to give you an ultra-long protocol. And sometimes with people with very low store of eggs, we may do a modified natural protocol. So the answer to that question is no, we will individualize the protocol to your specific needs. And we will try to do this to get everything just right for you, for your response.
Thank you.
I hope that answers that question.
Yeah, no, perfect answer. So you pass 1 point. So the second question for me, so it's deliberating PGTA testing. Should I go for that or care maps or both? So it's a bit of a complicated question in that we don't necessarily know why you might be undergoing PGTA testing. We normally use it to select, as I mentioned, embryos that are kind of genetically have the correct amount of chromosomes. If you've experienced kind of recurrent miscarriages, normally kind of over 37, 38, we're looking at kind of actually it might be a beneficial process to generate the most usable embryos in a treatment. It's not necessarily comparable to care maps as such. There is some studies out there that show the way they develop is indicative sometimes of the way the genetic component is set up, but that's not always the case. With PGTA, the care maps is included as part of that. So if you go with PGTA, you will get care maps. So you kind of PGTA and care maps are the same thing in that treatment option process. But care maps doesn't do the same thing as PGTA on its own. So
I think there has been quite a lot of interest recently. Papers published about morphokinetics. Can they replace PGTA? But I don't think we're quite there yet. And I think PGTA gives much more information about the chromosomal pattern than care maps does. But they go hand in hand. Would you agree? And that's why the care maps tool is part of the PGTA package that is offered through Care. I think if you are older, if you're an older patient above 37, I would go for PGTA definitely, and care maps will be included with your treatment plan.
Yeah. So the next one is, even if we have no sperm issues, could we opt to have ICSI?
I think that's your question.
So yes is the answer. The reason is kind of why would do you need to, and kind of what benefit do you get from that? When we do IVF, obviously we're mixing the sperm and the eggs. If the sperm sample's normal, then there's no real reason to expect that wouldn't work successfully. What we have seen using our data is that when patients kind of experience a long time of sort of no reason for forming a pregnancy, so sort of unexplained infertility, actually over 3 years, actually it's something that we recommend that you do, just because it's kind of, it maximizes the chance of seeing fertilization, because it's something that we're obviously not seeing in utero, sort of in a natural process. It does come with obviously an extra cost. There is some sort of risks in the lab. Obviously we're handling the embryos more, we're assessing them at a set stage rather than leaving them overnight, and obviously we're kind of injecting them with a sperm, which sometimes the eggs just don't survive that process, so you see what's called a degeneration of the egg during the ICSI process. It's really quite rare, and our percentages is kind of 2% of eggs, I think, across the board that don't survive that process. But obviously if you don't need it, is it something that's necessarily useful? We're also obviously selecting the sperm rather than the sperm doing that themselves. Obviously we select them based on the way they look, the way they swim, but obviously we can't see whether they're genetically normal or not, so we may have some carrier over of kind of genetically kind of imperfections, that kind of thing, when we do ICSI, when we don't need to.
Yeah.
Is that
I agree totally that if there is no indication, like a low sperm count or poor or low fertilization or no fertilization, or if the embryo development is okay, then I can't see why you would want to do ICSI with your very first treatment cycle, unless there's a reason to do so, because there's risk. It's more invasive. There is a higher risk of birth defects reported in babies born after ICSI in some studies. And so I personally wouldn't recommend ICSI as a first line of treatment in anyone whose sperm parameters are normal. And I think we have done an audit in CARE to show that even in people with very low egg numbers, trying to do ICSI to maximize fertilization rate doesn't help. IVF has the same outcome. So certainly I would say that no huge advantage.
Yeah, no, absolutely. Egg number doesn't play any kind of part in it. It's more overcoming those sperm factors. Yeah, and like Rima says, so if you don't necessarily need it, then it's probably not something that you want to just do off the bat.
Yeah.
So Rima, why do we have the BMI limit?
So the BMI limit is important. It is a little bit sometimes upsetting in clinic for some patients. So the BMI of the female partner is very carefully assessed. It is often the only marker we have about safety. So in a woman with a BMI of greater than 35, there is a higher risk of anesthetic complications at the time of egg collection. If for some reason there is respiratory depression because of the drugs used for egg collection, then the resuscitation process is far more invasive if you have a BMI of 35, and it is not safe to do that in many standalone clinics like we have in CARE. Secondly, we know that the pregnancy rates are a little bit lower. We know that the miscarriage risk is higher, and we know that the pregnancy complications are also higher. So at CARE, we do have a policy of, unfortunately, having to request patients to try and optimize their weight to get a BMI of less than 35 in order to ensure that we offer them treatment safely and we offer it more efficiently, and hopefully we will be able to support them by keeping in touch with them throughout this process when they try and optimize that weight. And that is why we have a cutoff limit of 35 upper limit for BMI at the time of egg collection. It is a safety issue, and it is also for their welfare, patient welfare during pregnancy.
Thank you. The next one is PCOS, and so I'm assuming that the patient has PCOS and hasn't conceived. Should I try ovulation induction meds or go straight to IVF?
Well, I think it's a good question, really good question. So with polycystic ovary syndrome, the main issue is that the patient doesn't always ovulate regularly. And therefore, if you are young, that means if you're less than, say, 38, and you've never had any treatment before, and you wish to start a family, I would definitely say that ovulation induction is the first line of treatment, because women who have polycystic ovary syndrome with tablets, 80% of them will ovulate within 6 months, and of those, 40% can conceive and have a healthy pregnancy and live birth. So ovulation induction is an effective form of treatment. But if you are older, if you've had prolonged periods of trying to conceive, or if there is a comorbidity, if there is another problem such as male factor, tubal damage, then obviously ovulation induction is not going to be successful. And in that case, perhaps going straight to IVF would be the option. So these are very individualized treatment plans made for patients. But certainly if you ask me, just like that, I have polycystic ovary syndrome, I'm 28 years of age, should I go for ovulation induction? I would say, of course, because that will give you a good chance of a pregnancy and live birth. But if it fails or you don't respond to treatment, then IVF is the next line.
Thank you. Very in-depth. So the next one is, are hormone levels routinely monitored through blood tests during IVF cycles, including frozen embryo replacement cycles?
So the question is very clear, routine. Is it routinely measured? During a fresh IVF treatment cycle, we do not routinely monitor hormones such as estradiol levels, because we use the markers from our scanning assessment to give us the same information. However, if there is any risk of over-response, or if we think there are other issues that need to be monitored, we will monitor the blood results. So, and it also is a little bit variable from center to center, but finally, the consensus from professional guidelines is that you don't routinely need to do a blood test. And certainly for frozen embryo transfer, we do not routinely, in an HRT protocol, we don't routinely measure the blood test. If you're having a natural cycle frozen embryo transfer, then we may have to do some blood tests. But routine, the answer is no. Specific circumstances, yes.
Thank you. So I have had 2 failed rounds of IVF, 26 eggs collected total. Not one embryo has made it to day 5 for PGT testing. I'm 38. Do you think it's best to move to donor eggs?
It's really tough when treatment hasn't worked how you would like it to, and I appreciate it's a difficult time for the couple. 26 eggs at the age of 38 is a lot of eggs. So I am suspecting that you may have polycystic ovaries, if not the syndrome, just a good. So I would say that just because it hasn't gone to a day 5 stage embryo for PGT testing doesn't mean you have to move to donor eggs. It does mean that perhaps your stimulation needs to be optimized to reduce the number of eggs we get, and perhaps that might improve the quality of the embryos, and perhaps look at what other things can be done in the laboratory to improve the chances of blastocyst development. And this is something that we would discuss at our MDT, as Stephen will tell you, and there are tools in the laboratory. So I would focus on reducing the number of eggs, trying to improve the egg quality, discussing at the MDT with our embryology team to ask if there's anything that can be done. I don't know what you feel about AOA and other such tools that may improve the chances of blastocyst development. And it's not essential for you to have PGTA. Even embryos that are not good enough to biopsy can still give you babies. So perhaps it's a discussion that we need to have further on an individual basis.
Yeah, absolutely. There's a couple of things we can do.
I would not recommend donor eggs at this stage. I want to know a bit more.
Yeah. And from a lab perspective, there's kind of modifications in media that we can use. So we can use EmbryoGen, BlastGen, or we can look at using AOA, so a calcium ionophore, which kind of can help embryos that have not previously developed a blastocyst because of deficiencies kind of get there just with a bit of a helping hand. So there's a couple of different things you can potentially talk about or look at that might help the process.
So optimized stimulation, changes in the laboratory, looking at how we can do things differently to give you a chance to have a pregnancy with your own eggs and sperm would be good to have a further review.
Yeah. And the next one is, please could you touch on, I think this one's for me. Please could you touch on sperm retrieval for men with no sperm seen in the sample? So there's kind of many different reasons why you might not see sperm in a semen sample. Sometimes it's obstructive, sometimes it's genetic, sometimes it's just that you're not producing it. Can be hormone levels, can be a genetic thing in the kind of production, or sometimes, like I say, obstructive, and there's sort of cystic fibrosis carriers can kind of be missing their vas, so the tube that connects the two. And there's lots of different things, and then there's kind of lots of different reasons. We do some investigations, so we look at your hormone profile, we look at your genetic kind of complement, and whether you're a CF carrier. So kind of have you got kind of 46 XY chromosomes as a male, and kind of check all of that prior to sort of embarking on a sperm retrieval. It is something that's successful for quite a lot of people that undergo it, and sometimes it's just unexplained. We don't really know how the sperm go from the testes to the ejaculate and become motile in the process. It's something that's kind of still not quite fully understood. So sometimes it's something that's completely kind of a mystery, and we'll retrieve sperm from a surgical retrieval where we wouldn't in the ejaculate.
So if I can just touch on that. So as a clinician, if I see a patient who has no sperm in the ejaculate, I would then try and understand, is it obstructive or is it non-obstructive? That means obstructive means something's blocking the outflow of sperm, or non-obstructive means it is not being produced in the testes. So the commonest cause for obstructive is, of course, vasectomy. And the second one is cystic fibrosis gene mutation, where you have a congenital absence of the vas or the outflow tract. The non-obstructive, where this testicular failure could be due to chromosomal or genetic issues, or it could be just something that we don't know why. And there's an external factor that it could be hormonal. So if it is obstructive azoospermia, which we will confirm by examining the testes and by looking at a blood test and the other results, then taking the sperm out from the testes is a very straightforward procedure. We're done under sedation. We just have to put a needle to the top of the testis and we can suck the sperm out. And that sperm is relatively good quality and motile. In obstructive or absent sperm because of the outflow tract being blocked, the success rate can be as high as 90-95% of getting sperm, and that sperm is of good enough quality to give you a pregnancy and live birth. But if you have non-obstructive azoospermia, that means the testis or the factory itself is not producing sperm because of chromosomal or other errors, then we can still try and get the sperm from the testis, but the success rate of that is about 50-55%, depending on many factors. So it could be just with a needle that we get the sperm, it could be with an open testicular biopsy, or it could be by a procedure called microTZ, where under the microscope we can look for the sperm. So all of these options are available to men without sperm in the ejaculate, and it should not ever mean that your journey has to stop there. We can evaluate this further.
So there's a similar question actually below that says, if I'm not successful on the first cycle due to my husband having low sperm quality, would a sperm donor be considered or suggested? I think we've just answered that with it. Absolutely not. It's not something we would consider as a first failed cycle.
If there is one failed cycle, and there may be many reasons for that. And, we learn so many things, how to improve the outcome from the first cycle. We may learn how to do the stimulation better. We may know how to prepare the sperm better. We may advise changes in lifestyle. So many things can be improved. And there is a term that we use called cumulative conception rates. And the National Institute of Clinical Excellence, which is our big professional guideline provider, says that even if you have had one failed cycle, if you have produced eggs, and if there is sperm in the ejaculate, cumulatively over 3 cycles, you can still have an excellent chance of pregnancy and live birth. So absolutely no, you mustn't give up, and you must make a further attempt. And we would be very happy to speak to you to understand why you should even, why sperm donor has even been considered. I mean, there are some situations where it may be absolutely very, very, very poor quality sperm, and that I can't answer just without knowing the details. But it's only in that very rare event that there is just a very occasional sperm, that may be a suggestion, but otherwise routinely not.
So next one is, I have a 10-year-old daughter with no complications and recent miscarriage in May 2023 at 6 weeks, then one yesterday. I'm really sorry to hear that. 5 weeks and 5 days. Myself and my partner are 35. What is the chances of me having a successful pregnancy next? Do I need to wait, and if so, how long?
I'm very, very sorry to hear about your loss. It is hard to have a miscarriage, and then 2 in a row in a couple of months is very hard. So first of all, I want to reassure you that by definition, recurrent miscarriage is 3 or more consecutive or non-consecutive miscarriages. But there are some centers like the European societies who define recurrent miscarriage as 2 or more miscarriages. So I would suggest that perhaps it may be appropriate to consider some investigations to see if there's anything correctable there. And certainly you're very young, you're only 35, so I would reassure you that most women who have more than 1 miscarriage will continue to try and fall pregnant and hopefully achieve a successful pregnancy and live birth, and you mustn't feel discouraged. It's just very hard for me to put a number to say what is the chance. I would just reassure you that you still have a very good chance, but perhaps it would be useful to have some tests to see if there's any small correction that can be made, or give you that reassurance that everything is okay and you can still continue to try naturally and conceive to have another healthy pregnancy and live birth.
So the next question is, after 7 miscarriages, I've had a successful pregnancy. This was being on progesterone. 2 further pregnancies have failed without progesterone. Could my issue be implantation?
So I'm delighted to hear. Just our previous question was about 2 miscarriages, and this is and you've had a successful pregnancy and live birth after 7 miscarriages, and you had progesterone supplementation. So there is a huge study published from the Tommy's Recurrent Miscarriage Center, which has shown that progesterone supplementation can be helpful in patients with recurrent miscarriage or threatened miscarriage. So implantation is when you don't achieve a pregnancy. So failing pregnancy after implantation is not failed implantation. It is a miscarriage or a biochemical loss. So I think that would be how I would say that you can see a recurrent miscarriage clinic to see if progesterone supplementation would be helpful.
Yeah. And the final question that I've got on our chat end is, at what point is egg donation suggested for secondary infertility? 2 failed rounds aged 40, getting blastocyst but failing to implant, using ICSI due to sperm volume and morphology.
Yeah. It's very hard when
this may be PGTA.
Yeah. So there are 2 options for you, and you are 40 and you're getting blastocysts of good quality. And I totally agree with Steve that if we are getting good quality blastocysts, perhaps the most logical thing would be to do pre-implantation genetic testing to see if we can find a normal embryo for transfer. But having said that, the chances of pregnancy and a live birth at the age of 40 is going to be about 20%. And therefore, 80% of each blastocyst will have an individual risk of being chromosomally abnormal. So I guess in a way, you have both the options of donor egg or trying with your own eggs to do PGTA testing to see if you produce a normal embryo for transfer. So it is going to be, I think, more a personal choice, and I think both options would be appropriate.
Yeah, bro. So yeah, I think that's all the questions that made it through to me. I don't think there are too many more. And the team have done a really, really good job of answering the ones that have come in through the questions. Obviously, I think feel free to direct them into the inbox, and I think Chloe will put that on there soon, and you can just send them in and we'll answer anything that comes in as well. Okay.
So we're very happy to respond to any questions that come through again, even after the chat event is over. and I'm sure the team will forward them to us, and we'll be very happy to respond to them and advise you to see if we can help in any way.
Absolutely. Right. I think that's the end. Obviously, like I say, point in a direction.
Thank you, everyone.
Thank you for listening to us. Hopefully it's been useful, and yeah.
Hopefully it's been useful. Thanks a lot, Stephen.
I'm Shah, and I manage CARE's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose CARE was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with CARE that didn't seem to be the case at all. They took everything into consideration, and they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to CARE.
Oh, the support at CARE was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared for by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success in treatment, we look to our own care family. From our consultants, embryologists, and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.
One in 6 people need help to grow their family. You're not alone. And our Care family will do everything we can to help your dream of family come true. There are over 50,000 Care babies in the world today, and behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.